Blood product transfusion. Blood products are going to be transfused to restore and or maintain fluid volume, improve the oxygen carrying capacity. We expect each unit of PRBCs to raise hemoglobin 1 gram per deciliter. We transfuse to replace deficient blood components or assist with coagulation. Criteria for transfusion means that we're not automatically giving blood transfusions if our clients' blood levels are low. We look for the symptoms that will prompt a transfusion and includes shortness of air, tachycardia, low blood pressure, chest pain, lightheadedness, and extreme fatigue. Most blood transfusions come from donors, and this is termed allogenic. The clients can self-donate, and that would be an autologous transfusion. When it has auto, that always means self. There are 4 types of blood, which consist of types A, B, AB, and O. There's also an Rh factor or antigen, which is either positive or negative, and this is determined by the presence or absence of the D antigen. So if it's present, the D antigen is present, it will be a positive. If it's absent, it will be a negative. Due to type O blood having no A, B, or D antigens, type O negative blood can be given to anyone in an emergency, regardless of the client's blood type and Rh factor. So type O negative blood is considered to be the universal donor. Due to type AB blood having no A or B antibody, these people can receive blood, or they can receive any blood. They are called the universal recipient. Now, if they do have a negative D antigen, then it needs to be at least the negative blood. Blood components can be administered as whole blood, but to decrease potential transfusion reactions or complications, such as fluid overload, whole blood is often administered in specific products. But let's look at some of our components. Our packed red blood cells, or PRBCs, contain about 200 to 225 mLs, and basically it's going to be blood where the plasma has been removed. It's indicated in fluid replacement, anemia, low hemoglobin and hematocrit, or symptomatic hypotension or dyspnea, etc. We will infuse this over a 2 to 4 hour period. Plasma, or FFPs, also known as fresh frozen plasma, is the portion of the blood that contains albumin, fibrinogen, coagulation factors, and it is given for fluid replacement, hypotension, coagulation deficits, and can be infused as fast as the client can tolerate. Cryoprecipitate will contain mostly clotting proteins, only fibrinogen and factor 8, 13, and fibronectin. It can be further separated out from plasma and administered all by itself. Indications for cryoprecipitate include factor 8 and or 13 deficiency and fibrinogen disorders. We can infuse this as fast as the client can tolerate. Usually the dose will be 10 to 20 units. This is often given with hemophilia. Platelets. Well, platelets are going to help with clotting of the blood. It is indicated when the platelet count falls below less than 20%, or I mean 20,000. Platelets are commonly ordered in 4 packs or 6 packs. Each pack will contain about 60 mLs. Again, it can be infused as fast as the client can tolerate. Granulocytes, these are white blood cells, and they're administered with serious infections that do not respond to antibiotics. It can be given for bone marrow, not making sufficient granulocytes, but it will eventually be able to do this again. Albumin, also known as protein. Now, this is a product that may be stored in the pharmacy, and it's usually indicated for poor healing. Sometimes we will administer this in the event of third spacing. And then finally, lipids, which are also known as fat emulsions. We might include this in parenteral nutrition, but it can be given on its own. It is indicated for fatty acid deficit or low energy. Now, in most states, LPNs are not allowed to initiate a blood transfusion, but they are allowed to monitor the client while they are receiving a transfusion. And they should report any potential reactions to the RN in charge of the transfusion. Policies for administering blood transfusions will vary, so it's very important to be familiar with and follow your institution's policies. Prior to the transfusion of any blood product, a blood sample will be drawn and sent for type and cross match. A type and cross match is done to prevent or reduce the risk of an antigen antibody reaction. The typing will determine the ABO and RH of the client's blood, and the cross-matching will check for any antibodies in the recipient's blood that might react to antigens in the donor blood. When this blood sample is drawn, the phlebotomist is going to place a blood band on the client's wrist, and the numbers on the band will be attached to all blood products and tickets that are attached to those blood products that the client will then receive. We have to get informed consent per facility protocol and then obtain client IV access. So peripherally, we're going to need at least a 20 or 22 gauge catheter recommended, but on occasion we can use that smaller 24 gauge if needed. And a larger gauge will be used if we need a rapid transfusion. Understand that all central lines can be used for blood transfusions. We will obtain a blood administration set, so tubing that is specific for blood transfusions. They have a built-in filter. It may be a set that has a one spike to it, or it may be a Y set that has 2 spikes and 2 drip chambers. The blood would be connected to one spike and normal saline is connected to the second spike. The administration set will be changed at least every 4 hours or after each unit of PRBCs if it is run over a 4-hour time period. Normal saline is the only solution to be used in the administration of blood products. We cannot use any other solution. Some healthcare providers want you to pre-medicate the client. Sometimes this will be with acetaminophen and or diphenhydramine. When the blood bank lets you know that blood is now type and cross-matched and available, we go obtain 1 unit of blood. We can only obtain multiple units in emergency situations, so understand 1 unit at a time is the norm. That unit of blood has to be initiated within 30 minutes of receiving it to the nursing unit. Each blood component container will have a label that identifies the product, the expiration date, and the blood type with the RH factor. In addition, the blood component container is going to have a tag or a ticket attached, and this identifies the product with specific client after the type and cross match is completed. It may also have a place for vital signs and the signature of 2 licensed professionals that check the product with the client. Once that blood component has been checked, we check it against the orders or obtained. We check it against the orders at the client's bedside with a second licensed professional. So basically, we match the following to what is on the blood ticket attached to the unit per the facility protocol. This is going to include the recipient's ID number, their name, the blood component ID number, the type of blood component, the AB and RH type, the expiration date. We also examine the blood component to determine that it looks normal. We're not seeing any clots or discoloration, gas or cloudiness to it, and that there are no leaks. We always obtain pre-transfusion vital signs, and then per facility protocol once the blood is initiated. For example, it might be every 5 minutes for 15 minutes, then every 30 minutes for twice, and then following the transfusion. We transfuse per recommendations or orders. PRBCs, we're going to start slow for 15 minutes and then slowly increase that rate to a rate to be completed within 4 hours. All other components can be administered at the ordered rate from the start. FFPs will be infused over 1 to 2 hours. Cryoprecipitates will expire after 6 hours. An IV line should always be initiated using the normal saline, and the blood product unit should be checked at the client's bedside by the 2 licensed professionals. Again, initiate the blood product within 30 minutes of receiving to the unit, and if the blood product is unable to be initiated within 30 minutes, return it to the blood bank. Vital signs are required prior to the administration, and per facility policy, we have to use tubing that has a built-in filter. The RN should stay with the client for at least 5 to 10 minutes after initiation to observe for reactions. We can use blood warmers with rapid transfusions. We can use pressure bags to increase the flow rate. And again, we may give pre-medication prior to the transfusions. Transfusing the packed red blood cells. Again, we can use smaller needles, but we should use at least a 22 or 20 gauge IV catheter. Administer each unit over 2 to 4 hours. Change the administration at least every 4 hours. Infuse slowly for the first 15 minutes. Monitor for reactions, and then we can increase that flow rate. One way to prevent the risk of infection and reactions with blood transfusions is to collect the client's own blood before a planned transfusion or planned procedure, and then transfer the client's own blood back into the client if needed. With the autologous transfusion, the patient will donate blood several times prior to the procedure, and that blood will be stored by the blood bank and then reinfused into the client if necessary. Basically, we've already gone over all of that. So let's move on. A little new memory device. When we're monitoring, never add medications to any blood component. Never transfuse if there's any discrepancies noted during the check of the component. Never piggyback into any solution other than normal saline. Again, we obtain vital signs prior to the transfusion, then at least 5 to 15 minutes after initiation, and per our facility protocol. Always monitor the insertion site and monitor for any side effects, which will include fever, chills, and I'm talking chills basically from the fever, not chills because they're cold. Chills because they're cold, that's not a reaction. Rigors, headache, nausea, facial flushing, rash, back pain, or dizziness. If any of these side effects are noted, stop the infusion immediately, disconnect the administration set, and connect a new set with normal saline to the IV catheter. Obtain vital signs of the client, obtain a urine sample, have the lab draw a blood sample, notify the healthcare provider of the client's condition, and treat the client's symptoms. Return the blood bag with the ticket and the administration set, including the normal saline, to the blood bank. And then we initiate just a normal saline infusion. Be aware that mild reactions may not require discontinuation of the unit. It may just require slowing of that transfusion rate and administration of medications, such as the acetaminophen or diphenhydramine, but the healthcare provider makes that determination. So as nurses, we always discontinue until we're told differently. With all clients, but especially older adults, we always monitor for fluid volume overload. So there's several types of reactions, but there's going to be 3 main reactions we discuss in this course, although there are 4 main types. The hemolytic is an antigen-antibody reaction to ABO incompatible blood that happened shortly after starting the transfusion. In other words, it was not appropriately type and crossed, caused by incompatible blood, and it can result in renal failure and shock and be life-threatening. We can have an anaphylactic reaction, which is a type 1 hypersensitivity reaction to the plasma proteins, and that will happen within 30 minutes of starting the transfusion. It's caused by an allergen that is present in the transfused blood, and it will cause those allergic symptoms such as hives, itching, fever, chills, facial swelling, wheezing, and/or a sore throat. A febrile reaction is where the recipient's antibodies react to the donor leukocytes, and this will happen within 30 to 90 minutes of starting the transfusion. It is caused by the client's antibodies reacting against antigens to the donor's white blood cells or platelets. This will cause the flu-like symptoms, chest pain, and hypotension. Circulatory overload is where the client's cardiovascular system is unable to manage the additional fluid load, and it can happen anytime during the transfusion to several hours afterward. With all clients, but especially the older adults, we have to monitor for fluid overload. Symptoms, once again, include the back or chest pain, fever, chills, and again, not chills because they're cold, decreased blood pressure, urticaria, which is hives, wheezing, dyspnea, or coughing during the transfusion. So once again, stop the transfusion immediately, disconnect the administration set, connect a new set with normal saline, and start infusing. Obtain vital signs, immediately notify the provider, nursing supervisor, and the blood bank. If it is a true reaction, you're going to be required to remove and return that blood bag and tubing with the ticket and normal saline to the blood bank. Again, mild reactions may not require that discontinuation. It may just require slowing of the transfusion rate. It may require medications to treat the symptoms, but the provider makes that determination. We will then treat the symptoms. This may mean administering oxygen, epinephrine, steroid, furosemide, and antipyretics or antihistamines. Be prepared to collect blood and urine samples from the client and complete appropriate documentation. A little assistance there.